So this webinar is to present a paper that's come together because of the help of a lot of people. Essentially, what we endeavored to do was to collect the most robust data that we could within the constraints of it being a prospective registry-based study, looking at all cases done with the V-STRUT device in the US consecutively from the very first through to the 52nd. Obviously, more cases have been done since the time that this was collated and submitted for publication. So the number is far larger than 52, but I think it's relevant and useful because this is the very first 52 patients from patient 1 through 52 in the US. And obviously I'd like to sincerely thank Majid for his help with the paper and his guidance, and also High Prevention and Cecile, obviously, with their significant help in coordination. So without any further ado, we're going to crack on. I have some conflicts with companies that are involved in the neurovascular and spine space, and I just want to say that I am a consultant for High Prevention and part of the advisory board. Similarly, for Dr. Khan, these are his disclosures, and he's also a consultant for High Prevention and on the advisory board. So the V-STRUT device, what are we studying? Sorry, if people could put mute on, that would be great. So it's a transpedicular implant that we use for osteoporotic and malignant fractures of the spine. It's indicated for fractures throughout the thoracic and lumbar segments. And you can see from the diagram in the top right that it's placed down the pedicle into the anterior middle column of the spine, and you can cement through it. There's a range of sizes in terms of lengths, but also diameters. And you can see those on the right. There's 4.5 millimeter diameters, which has really become the workhorse in most people's practice, all the way up to 6.5. There's been some other studies done in terms of finite element analysis, which has really helped to direct how we use this in terms of pairing it with PMMA and understanding what the reasonably ideal volume of cement would be in your average size vertebrae to get the best out of this device in terms of compressive load redistribution. Comes with a reusable instrument tray that you see in the bottom right. So this is re-sterilizable. And its indications, as we talked about, its current indications are from T1 to T5 throughout the thoracolumbar vertebrae for pathologic and osteoporotic fractures. And it's also importantly indicated for fractures of the pedicle or tumor involving the pedicle. Okay, and that's its uniqueness in the market at the moment in terms of other devices that have this indication. So this is a study, it was a retrospective study, multicentric patients treated within the United States from October 2024 to May 20, those dates are off, but basically it was from 2022 or 2021, I think was the first cases that we put in through to May of 2024 when we finished up. The decision for treatment was really solely at the physician's discretion. So it's not randomized. This was based on what the treating physician deemed appropriate for use in terms of the device and the appropriate patient. So there's obviously an element of selection bias for these kind of cases, but nonetheless, its inclusion criteria really was every patient treated within the first 52. Because of the timing of the study, the fractures really were between T9 and L5, and that was the first indication in terms of levels before it was extended to T1. And the initial sizes were 5.5 and 6.5 diameter implants. 4.5 wasn't available or developed at that time. So all of these were with 5.5 and 6.5, I think, from memory. And we have follow-up data at 1 month in terms of VAS outcomes and 6 months, but also follow-up data in terms of adjacent and remote level fracture rates, but also refracture at the target level out to 6 months. So this is the population treated. So gender, male, female. In terms of total population, osteoporotic were the majority of cases, malignant were the minority. Age and years in the 70s, so a typical patient population that we see with osteoporosis, slightly younger in the malignant group. Fracture etiology, as we said, broken down by population, and fracture age. So these patients roughly about 5 to 6 weeks of age in terms of fracture age, and that was similar across malignant and osteoporotic. We tried our best to be as granular as possible with the kind of fracture morphology that we had using the GEN, the OF and the Vertebral grades. I typically use Vertebral in terms of fracture identification and classification for when I'm treating them. It's just a personal kind of thing, but I know people use GENET and the AOA classifications as well. But the thing to garner from it is that, you know, it's really focusing mostly that we could see on these A1 fractures, which is typically most of the fractures that we are treating. And in terms of location, you know, a significant proportion of these are junctional and mobile levels between T11, T10 and L4. Maybe a little bit different to our general population of treatment. Most or many of these patients will be treated with general anesthesia, which I think is probably a factor of comfort with a new device and understanding just how stimulating this procedure could or may not be to patients when we're using them. As we've progressed along and used this device, we typically intend to use it more in the same vein that we would kyphoplasty in terms of sedation. If it's multiple levels that we're treating, then the indication for us would be general anesthesia just because of procedure length and patient comfort. But if it's 1 or 2 levels, then we would go with max sedation. And that's been an evolution of a change over time. In terms of cement volume, you can see that, again, because some of that FEA study I was talking about, the ideal cement volume came out a little bit later in the piece, that we were using this device maybe more similarly than we would with kyphoplasty in terms of cement volume, so a little bit more than what is generally suggested, at least by the FEA study. And procedure minutes from timeout commencement to dressings on is about 48 minutes. So in terms of fractured levels, this mimics what we talked about in the previous study, showing yellow is malignant, blue is osteoporotic, and green is the total population. So the majority of fractures are really between that L3, L1, T12 kind of level. And again, I think this is probably from a comfort level, understanding that this data comes over 2 or 3 years, and there is gradual comfort in how to use this, placing these devices transpedicularly in the thoracic levels or levels where there are ribs coming off. It's probably something that people would need time to get comfortable with, that we focused really more across most of the practices with these high lumbar kind of levels. Most of the implants are 5.5 and 6, if not all of them. And because of the market within the US where these cases came from, or most of them, we saw Stryker had the majority of cement.
But as Reid, you mentioned in this study, there's a little bit of bias because at that time we were not using it above T9. So that's why you don't see a whole lot of mid-thoracics involved.
Yeah, and I'm not sure if this fits with your practice, probably different to mine, but I when I started using it was certainly favoring to using it at levels away from thoracic segments, just as basically dipping our toe in and seeing how it would behave and seeing how comfortable we got in putting these in and how quickly we could put them in. But that's certainly changed over time. These are the clinical outcomes in terms of pain reduction. And I think it'll be shown graphically on the next slide, but there's a couple of things to understand. And this isn't to say that this is different or better or worse in terms of pain relief than kyphoplasty or vertebroplasty. I mean, everybody on this call who works in the field knows that these interventions work. You know, it's mechanical pain from bone and fragments moving. You stick them together, you gum them together, and that mechanical pain will go. But when we look at it, this is more to say that this mimics what we see with the other kind of interventions that we have for spinal fractures. So it's not provoking pain or making things worse typically. A reasonable follow-up out of the 52 at 1 month, so 44 for the total population. There's attrition to 6 months, which is fairly typical with what most of us see in our clinic and our practice, but 63 to 65%, I think, for osteoporotic follow-up for a retrospective registry is actually really admirable. And, you know, I pay some respect to the other co-authors and procedurists on this study because they really tried their utmost to get these patients in. And we can see that those pain scores decrease quite predictably, and it's statistically significant at each time point. So this is the change over time, and you can see an indication of how many patients were available at follow-up as we move along. So clinical outcomes in terms of adverse events, so 22% or 21% adverse event rate. To take this with a little bit of a grain of salt, and cement leakage, if you really think that's an adverse event, like most people don't, unless it's symptomatic cement leakage, but we include it for completeness. So that was 7 out of 52 patients, so 13%. If you remove that, it's really 4 patients with clinically relevant adverse events in the follow-up period that we could track of the patients that came for follow-up. So there was no subsequent fracture or significant collapse at the targeted level within the group. Again, these are all self-reported imaging outcomes. It's not core lab based, so we praise it with that. Adjacent level fractures were seen in 4 of 52 patients, so just shy of 8%. And adjacent fractures in the osteoporotic group, excluding the malignant group, was 3 of 43, so 7%. And again, remembering that this is there may be a bias in terms of returning to follow up. You'd think if you had severe pain after procedure or new severe pain after procedure that you would follow up with the surgeon or the interventionist that did the procedure. So you might even be inclined to think that if there were more complications or issues that they would be more likely to come back, but we obviously can't infer that with any degree of certainty. And then we can go on with some cases. I could show this one, and then Majid, you might want to take over and show the others. This was just one of my cancer cases. So it's a male, 74, prostate cancer at L4. We used the Stryker Optoblade system for ablation. This is what the system looks like when you're placing it. These are the guiding tubes throughout the skin, the tissue dilating tubes. That's the drill or the auger to drill the pilot hole for the device. That's your K-wire, and this is the device in position with the distal tantalum marker telling you its depth. This is with the cement placed. This is what the device looks like at the pedicle end. Okay. Here's another patient. Majid, do you want to? Actually, this is another one of mine, so I can do this. This is fine. 72-year-old patient, osteoporosis, L1 and L2 fractures, little superior end plate fracture up here, more of a cleft fracture at this level, had pretty severe pain. We just filled the bottom one with cement. We didn't use the devices in the cement in there, and we didn't use spine jack, but placed the devices at the level above because biomechanically, our understanding or the rationale for using this and applying this is to hopefully and theoretically decrease your risk of adjacent level fractures in these patients at junctional levels. So placing these at least on first principles at the level above or below the treated level or at either end of the construct, I think makes the most sense to help offload those adjacent discs and adjacent vertebrae. And again, this is a bit of a paradigm of thought based by benchtop testing and the FEA analyses and studies that Rita Hambley and Cecile have worked on previously. This is follow-up. Patient tolerated procedure well, had good VAS response at 1 month, no adjacent level fractures in follow-up. So Majid, do you want to take over from here?
Yeah, sure. Thank you. So this is a patient of mine that had bladder cancer, and you can see this metastasis, the lytic metastasis that is involving most of the vertebral body. So as Reed also showed in the previous case, so we did radiofrequency ablation of this, and you'll have to move it. So, and here you can again see that we wanted to fill up that whole lytic lesion, and very nicely it was filled up, and the patient had really good pain relief after the procedure. The thing that is different with this implant is when you put the cement, like with most other kyphoplasties that we do or vertebroplasties we do, the cement comes off from the distal tip of the cannula that you're using, whether you are using the automated or you are hand plunging. But here there are holes on either side of the device, so there is the cement comes out circumferentially 360 degrees. So it kind of fills up the vertebra both medially as well as laterally, and so that's perhaps I really like that about this device is that it's a very uniform fill that you can see spreading across the vertebral body, especially on your AP image. And that's one of the reasons, as Reed had shown in his case, is that just like other implants that we put in, you have to come to the midline on the AP image so that you don't want to be on the sides on the ipsilateral thirds because of the cement coming out laterally also, and you can extravasate the cement there.
Okay.
This is a very recent case that we did. This is a 93-year-old, very functional lady who had this I think T12 fracture, severely osteoporotic. Her score was about 3.8. And here you can see we are accessing the pedicles bilaterally. This is the drill that has gone in. So one more thing is that with these osteoporotic bones, you can just put the drill in and you can measure the length of the vertebral body and then use the appropriate sized implant. In some of the pathologically fractured, you may have mixed density bone, so you have to probably, if the bone is quite hard, you have to really drill twice because with the first one that we put in really creates a channel for this second drill, and then the implant goes in very, very nicely. So you have that capability also with this, and we have put this on one side, and now we move forward. So yeah, so then we're putting the implant from one side, and after the implant has been deployed on one side, we start to work on the other side. Forward, please. Now this is the other side going in. Forward, please. And now you can see both the implants are in place. You can go all the way to the anterior third of the vertebral body, but this is a good place to be at. And then you can see as we are deploying the cement, very nice fill. You can see one more, Reed. So you can see how nicely this vertebral body is filled up, and you can see the fill from medial to lateral, complete fill of the vertebral body, and that. And then we have some post images also. So these are the post scans. You can see the implants there, and then this was actually this is, I said 6 months. This is a month follow up CT, and you can see very, very nicely there's filling of the vertebral body, and the patient really didn't have any pain at 1 month follow-up that we did on this. So extremely, and this was also a junctional zone fracture, so that was very helpful. Again, in a severely osteoporotic patient, you don't want them to fracture the adjacent level also. This is not one of my patients. This is one of the patients in the study from our other colleagues. So 55-year-old osteoporosis, T12 to L3 fractures, pain 9 out of 10. And you can see this is likely a 2 fracture. And there you can see the devices have been deployed at multiple levels. They're measuring the pedicle volume, the width of the pedicle. As we said, the 5 millimeter is probably the least that you would want to get. Have we done it with less than 5 millimeter? Absolutely. But what's recommended is that you have a cross-sectional study, measure out your pedicles width, and then use the drill and the implant accordingly. And again, you can see very beautiful fill both centrally as well as peripherally with this, and the device implant is very satisfactorily positioned, as you can see, going from medial to lateral and at the back end of the pedicle. Go ahead, Reed. Do you want to take it?
Yeah, these aren't our cases. They might have come from Dr. Cornelis or another one of the physicians, but nonetheless, they're really interesting and nice examples. These were probably after the study. I'm sure they're after the study cohort. But again, you look at these previous, it's kind of following that paradigm we were talking about offloading the adjacent levels above and below with the device, and treating with cement at the intervening levels. The whole kind of rationale and purpose for this is to try and restore some normal flexibility and compressive forces to the spine, rather rather than just putting cement in or cement in and a titanium implant. Because at the end of the day, we know these interventions of ours, they treat pain, they're fantastic at treating pain, but the bugbear of our specialty and our follow-up is adjacent level fractures in these patients. And, you know, overarching and critical to that is managing their osteoporosis as aggressively as possible. But that's often, you know, that's a marathon. That's something that you take care of over months to years. And any ground that we can make to try and avoid these patients coming back with fractures by more bespoke and I guess, hesitate to use the word, but, you know, thoughtful kind of intervention for these kind of lesions, I think is something really for us to look into. But this looks like a patient, 57, lung cancer, and this is a patient with pedicular involvement. You see it in the right pedicle on the axial slide on the bottom right. So again, this is one of the only device really that I'm aware of that has pedicle treatment as part of its indication for oncology. So patient treated under GA, 2 V-STRUT implants with cement from Stryker, good spread of cement centrally. You can see it more patchy and more cloud-like on the left, like fitting more with trabecular marrow, and filling a more amorphous kind of globular appearance, which fits with the tumor involvement in the cancer side on the left. And you can see that asymmetric collapse in that right half of the hemivertebrae on the AP. But it looks good, and the physician reported that the patient had excellent expected pain relief. This is another case which I'm certain is from Dr. Cornelis at MSK. 57-year-old patient, osteoporosis, breast cancer, T11 and L4 mets, fractures, 100 out of 100 pain. Looks like they've had previous kyphoplasty at these upper lumbar levels, and they've developed these adjacent level fractures in T11 and L4. This is some of the intraoperative imaging. This is what your access channels with your working tube, I guess it is, for injecting your cement and implanting the device. This is what the spot films look like during the procedure. And you can see the post-op cone beam CT with, again, as Majid described, a really nice uniform circumferential kind of distribution of cement, much more akin, I guess, to what we used to see with just vertebroplasty. And again, on the cone beam CT, you see these are the tandem markers at the back of the implants, tandem markers at the front, and there's some cement within the actual central channel of the device.
And really, Reid, I have seen, if you go back, I've started to see like where you do balloon kyphoplasty or something, like you form like a blob of cement, and then that ball of cement increases as you increase the volume of the cement. Here, as Reid really described it nicely, it's like the cloud of cement that disperses off very nicely, uniformly across the vertebral body. And who knows, honestly, that may be one of the reasons that we at least in this study, that we saw that there is a decreased incidence of the adjacent level fractures. I know there have been studies that are being looked at where you have cement within the vertebral bodies not touching the end plates versus cement being completely filling the vertebral bodies and touching the end plates on both sides. And people are looking at it whether one has increased incidence of adjacent level fracture over the other. So many studies are out there looking at different permutation and combinations, but I really feel like that, as you can see in this image, centrally where the implant wasn't used, it's like a big blob of cement, versus where the implant was used, it's like more uniform distribution of cement without that concrete ball in the center.
Yeah, that's a really good point. So these are some of the other publications that are available regarding the technology, both preclinical, so FEA studies, 2 of them, and you know, anybody interested, I really recommend you tracking these down and having a read and having a look. They're quite informative. It's very hard for us to get good bioengineering kind of data and biomechanical data en masse from from a large group of patients, because obviously there's challenges with follow-up, and challenges with imaging, and challenges with just the practicality of practice. So these FEA studies are actually really quite very useful and provocative in terms of conversation and trying to understand how we can make little changes in our practice that theoretically can benefit patients significantly. Is a paper by Vertebral et al., which was a pilot 1-year study. I believe that was done out of Europe. And from Vianney et al., biomechanical response to spine segment treated with V-STRUT and vertebroplasty techniques and finite element comparative studies. So some really good biomechanical engineering studies that are available to review. So next steps in terms of what's on the docket for clinical understanding of how this device can be used safely, effectively in oncologic and osteoporotic fractures, assessing the feasibility and performance for treatment of pedicle involvement, trying to understand how this fits and how it helps to hopefully prevent and avoid more of those kind of failures in kyphoplasty that we see in junctional level fractures, where you have shearing at the base of the pedicle and ongoing collapse of those levels. I think you see from the 52 patients that and most of these were cases between L1, L2, L3 or and T11, T12. But those are the places, the fractures that are most under flexion and distraction. And there's some excellent work by Alessandro Ciaffoni a few years ago or some years ago, again with FEA evaluation, showing that when you put cement in the anterior column of a vertebrae and you leave that bare area or back of the middle column, pediculosomatic junction, without cement or without reinforcement, that under normal physiological circumstances, a significant amount of compressive force actually shifts to that area, and that's somehow part of that soup that leads to these target level fracture failures, where they can go on and collapse, and anybody that does a reasonable amount of these kind of cases, through no clinical fault, we'll see those patients come in just because it's the nature of the beast. So we're trying to see if this is going to avoid more of those kind of return patients. And obviously we need to qualify and reproduce these kind of findings that we've seen in terms of adjacent and remote level fracture reduction in larger, more robust prospective clinical samples, followed clinically out to 6 to 12 months and followed with core lab imaging. That's the thing that's going to really cement, I think, in a lot of clinicians' minds, in our minds, that this is something that's actually really valuable in terms of ongoing patient care and patient management. So that's the end of the slideshow. I can stop sharing and we can open it up to conversation and discussion.
So just add that what Reed said in that last slide basically is what we're looking, how this device is different from our regular vertebroplasties and kyphoplasties. Is what you are doing with this device is that you're kind of dissipating the axial load between the vertebral body and the posterior elements, which is how normally it is in a normal healthy individual with the normal height of the vertebral bodies. With the fractures, the dissipation of the axial load is altered, and especially in osteoporosis in older people, it's with age that 70-30 distribution of axial load dissipation is altered anyways, and with fracture it gets altered much more. And that's why with this device you're trying to at least balance out a bit between the body and the posterior elements, and that's likely one of the reasons that we are seeing no subsequent level fractures and decreased incidence of adjacent level fractures. Granted, as some of you who must have read the paper, our paper, we definitely, our numbers are much less than Seiko's and other studies using balloon kyphoplasty, but as we have said in the paper, Seiko's trials, spine jack was pretty much used more frequently with moderate to severe compression fractures. This device is not for height restoration, so that's a little bit of limitation, but still, overall, we feel like that one of the most advantageous use of this device is that the adjacent level fracture. And as we do more and more cases, get our numbers high, that's something that we are really looking at and seeing if that number stays where it is overall.
Yeah. You know, I see this device and all devices that are coming through within the fracture space as beneficial and advantageous to the field. You know, when you think of spinal fractures as a complex bone, it's not a long bone. It fractures in multiple different ways, in interesting ways. It's very prone to osteoporosis and tumor. Yet our approach to it is probably overly simplified in terms of how we attack fixing them. We've got like everything looks like a nail because all we have is a hammer for so many years in terms of balloon and cement. But really, I think probably we need a little bit more of a bespoke kind of approach to fixing individual kind of fractures and fracture patterns. That's why I like, you know, the Majeral classification. I like trying to think about where does this device fit? You know, vertebroplasty most appropriate, is spine jack most appropriate, is balloon kyphoplasty, is V-STRUT, whatever. Because you know, there's no one size fits all to all these kind of fractures and all these patients. And you know, it's just a very complex biomechanical structure, like we said, incredibly prone to osteoporosis and one of the most, if not the most likely place for lytic and sclerotic nets in the body. So
Absolutely agree, yeah.
Do you always drill with the same size drill as the implant you're going to use? Do you ever undersize? Because then, you know, like when we do pedicle screws, you usually undersize your tap or undersize a drill. But I'm assuming you probably use the same size.
Yeah, no, you use the same size for this because it's essentially a press fit, like a snug fit device. If you undersize it, you won't be able to get it down the pilot hole that you've drilled. Or if you do and you do it with force, then it's going to be smushing the bone and the marrow as you go in. So the drill is sized to the appropriate caliber of the implant that you use.
And how much more cement do you think you get in a level versus kyphoplasty? Is there a percentage you think, or something that you can?
I'll be interested in matches, but I think, you know, I use a lot less cement with V-STRUT than I would typically with a routine kyphoplasty. You know, routine kyphoplasty, obviously compressing and creating a cavity, and that cavity is a certain shape or size. With it, be it like spine jack or balloon, so you have to fill that space with cement. You have to get that cement to interdigitate within the normal marrow adjacent to it. So, you know, in a bloke, in like a male in a mid upper lumbar vertebrae, I'd say on average we're using about 7 cc of cement to get a fill with standard kyphoplasty. And with the V-STRUT system, again, because you're not really destroying or damaging any of the trabecular structure around it, and like Majid was showing, the cement tends to permeate through that trabecular structure, that you know, we're using somewhere around about 4 to 5 cc probably.
Yeah, and I agree. This is just with the implants, you use less cement, and same as with this. And that's why I made that statement that the 360 deployment of the cement is very, very helpful because it just permeates medially and laterally. So you're not really forming a blob and then you have to increase that blob of cement all the way up to touch the end plates. So definitely the amount of cement that we're putting with this is less compared to your regular balloon kyphoplasty, but the dissipation is much better compared to the pre-created cavity.
Visually, it looks like there ends up being more just because it's spread so much.
Exactly,
So
exactly.
It's deceiving to hear that because it looks as if you're getting more because it spreads so much more.
Exactly. That was the whole point, because it just dissipates all over, and without breaking the trabecula, it just fills from both sides, medial and lateral.
And then I'm also assuming that the ports for the cement to come out stop at some point, so they aren't coming out in the pedicle, I'm assuming.
Yeah, there's
like they're only at the distal end or something.
Yeah, it's a manual, or at least the way I use it is a manual cement injection. You fill up a cannula using whichever cement provider that you have, and that has a pusher that, a coaxial pusher. You put that down your port, and you can see it's radio opaque going down the center of the device, and you can control how deep into the vertebrae or how proximally you deposit the cement by just pushing and moving that backwards and forwards. So if it's going to a portion of the vertebrae that you're not so happy with, then you might pull the cannula back. That stuff will harden and act as a bollard to help redistribute the cement in another distribution, or sorry, in another region. But it's controllable. So.
Yeah, I don't use a plunger. I use the automated system, and pretty much the same. It's under your control. You're watching where the cement is going. When you want to pull out the cannula, put more cement in, it's under your control.
The other thing I'd ask is, I've done lots of kyphoplasties and vertebroplasties, and when I see cement leave because of fractures in the bone and it ends up escaping, going in in places you don't want to see it. What is there anything new that comes about with this technique as a complication that I'm not going to be used to?
Not so much. I mean, the way the cement distributes is controllable. You have to work it to make sure it stays where you want it. Like, as I said, if it is going to a portion of the vertebrae or the margin of the vertebrae you don't like, you have to stop and then reposition your injecting cannula. Really, cement's going to go down path of least resistance if you've got a big coronal cleft fracture or sagittal cleft fracture, or big cleft that's traveling up into the disc or out the front of the vertebrae, then the cement's just going to go down that pathway and exit. So it's just something that you have to manage with your injection. There are people that really like this device in clefts, or other colleagues that I've talked to that have been using it in clefts. I tend not to, just for that risk of the cement traveling down there and not interdigitating with normal trabecular marrow. That's the whole thing that I like about the system is, less cement at adjacent level, upper or lower end of your construct, where your marrow is relatively intact. You don't have these big cracks running to the disc, and you can get that really nice distribution of cement, and ideally get a much more physiologic biomechanical kind of moment traveling around that margin of your construct, rather than using it specifically for really shattered vertebrae. But there's some people that really like it with clefts and that kind of stuff, but it's just not how I apply the device.
So for me, like what you said, that if the cement is extravasating, if it's, say, for example, it's gone into a vein anteriorly, I would probably wait about 4 to 5 minutes. I waited at times, let the cement harden a little bit, pull my cannula a little bit away from the cortex that it is coming out from, and then started to push the cement again. Of course, watching that cement is not propagating in a vessel, or if it's a lateral leak, it's not going out, forming a blob in the lateral. So, but I think I have had fair amount of success by waiting 3-4 minutes, let it harden a little bit, and then push more, but pulling the cannula away from that area so that I can dump it on the back end. So that has worked pretty well for me. That sometimes mean that you will be wasting the cement. If you wait 5-6 minutes for one level and you're doing 2-3 levels, you can probably go into the other level and do the other level first. So that's another way of doing it. But sometimes I had to open another cement just because I waited too long, but it was good for the patient in the end.
Any other questions from people viewing? Yeah, I mean, as I said, the fundamental thing that I try and look at with these kind of devices that are coming out is that it's part of a toolkit. you don't want to be too dogmatic about any one way that you have to treat these fractures, but trying to be a little bit more understanding of the kind of fracture that you're dealing with and applying the appropriate device and appropriate technique to the appropriate fracture, I think is useful. Where I'm really interested and happy that this device is available is specifically in those patients with lytic oncological disease involving that middle column. Low-grade Bilski, but ones that are involving the base of the pedicle somatic junction, where you really do, I think, need something more of a 360 kind of reconstruction to feel more comfortable that that's not going to collapse should you leave some of that tumor after your ablation, and should it not be successful with EVRT or radiosurgery. So those are the patients where I think that this, fits really, really nicely with my practice, but also in those patients with multiple fractures where we're trying to offload the adjacent level above or below.
I think, Cecile, I saw a question about reimbursement. You want to answer that question?
Yes, sure. So regarding the reimbursement, for the moment, we use the CPT code for kyphoplasty. So at the hospital, there is a CPT code, outpatient or inpatient. And as we have a special feature with this device that is a reinforcement of the pedicle, we are working on collecting clinical data in order to apply to CMS to try to have an additional payment for the implant itself. So it will not happen tomorrow. It may take us a few months. We plan to apply in 2027. So we will try that to have an additional payment for the device at the hospital. So today, most of our users are at the hospital because the reimbursement is enough for an implant compared to a regular kyphoplasty.
Yeah. And Cecile, how much difference is in reimbursement in hospital compared to ASC or?
In ASC, it's half. So yes, if you do a kyphoplasty at the hospital, you will get, the ASC will get half of what you get at the hospital outpatient. So that's why in ASC, they mainly do a regular kyphoplasty, but they don't do V-STRUT and they don't do spine jack neither because it's an implant and there is an additional cost.
Yeah.
It's, yes, less than half.
How much longer does the procedure take than just cement only? Did I hear you say 20 minutes more?
From
the
paper, the average procedure time showed about 38 minutes skin to skin. So, and understanding that I think there was 10 or 9 different surgeons or interventionists that contributed their first cases to it. So, there's a handful from each. Everybody's on a learning curve. Like, okay, this piece with this is what we're going to do. We're going to take our time, make sure that we've got the process down. So it's 38 minutes. I think that's, really excessive compared to how long it takes us to do a single level now. And I'm sure Majid is the same, if not faster. But typically for us, if we're doing a single level, it's probably in the order of about 20 minutes, give or take, maybe 1 or 2 more, or 1 or 2 less, depending.
Yeah, we're a little bit skewed in the sense that we have trainees with us, so that definitely increased the procedure time. But I completely agree, 20 to 25 minutes max now if we do it on our own.
The last case you presented with from Dr. Cornelis, where he used 2 V-STRUT and 3 vertebroplasty, it took him 60 minutes, so 1 hour for the 5 levels. He used only 1 dose of cement for the 5 levels, so I implanted 2 levels with V-STRUT and 3 vertebroplasty.
Great.
So,
in terms of, post-operatively, I guess that's something we could talk about. It's a lot of kyphoplasty, or at least curette-based kyphoplasty or curved needle is a single access. Obviously, this is two access points, similar to more typical kind of balloon kyphoplasty. you need an incision long enough to be able to get your working tube down, and your tissue dilator that's, you know, a bit under a centimeter, if that. Usually you can glue those shut and use a stereo, or you can put a single stitch in. We'll typically do that. But in terms of post-op pain, sometimes they have a little bit of muscular discomfort for a couple of days, or spasm-related pain from going through the muscles, but it's very rare. Most of them recover very quickly and very reasonably, and follow the same kind of trajectory that we see with those patients with mechanical fracture pain.
Yeah, I rarely, as I said, mostly steri strips or something. We have rarely put a stitch in. We just try to roll the skin a little bit after we are done with the procedure. That helps quite a bit, and but rarely, even stitch is not needed most of the times. And then the regular follow-up that we do just for what you do for your kyphoplasties and vertebroplasties in terms of weight limit and strenuous activity and all that, that applies to this procedure also. So nothing different.
Any more questions?
I just have one comment. One of the cases that Dr. DeLacy pulled up may have been a local case here in DFW, 4 levels treated. I want to say on that particular case, he attempted, our doctor attempted 3 levels with V-strut. However, the pedicles just were slightly too small to accept the implants. So we were trying for 3 levels, but he ended up doing kypho on 2, V-strut on 2. So I believe that was done here locally.
Yep. Yeah, so, you know, obviously everyone gets cross-sectional imaging on these patients. Typically, you can very reasonably and easily, you know, measure your axial transverse dimensions of your pedicles, make sure that the organ is going to fit in there and the devices fit, and then go from there. You know, in terms of keeping the access point smaller, you can measure the device off the CT if you feel one. If you don't want to put in the working tube and just work over a KY with a drill, that's a completely reasonable way to do it as well. We typically use the working tube and the tissue dilator tube just to give us a little bit more stability with the KY.
Thank you for presenting, and
Happy holidays, everyone. Thank you.
Yeah,
Happy holidays.
Thank you, Dr. DeLacy. I appreciate it.
Bye-bye.
Thank you so much.
Have a good one.
Bye-bye.